Hi guys, this is Dr. Wallace, and we're on the last information section of this NPLEX Pharmacology Elective series. So we're covering today the Psych and Immune Pharmacology. That is going to include oncology, immune, and then next week we will be doing a review. So this is our last section to kind of push through, and then we'll see, we're almost there. Okay, so here are our psych medications. We're going to be covering these categories: SSRIs, SNRIs, tricyclics, MAO inhibitors, atypical antidepressants, ADHD meds, anxiolytics, mood stabilizers, and antipsychotics, both atypical and typical. The antidepressants are going to be the first bucket we're playing with, and so we're going to look at the SSRIs, including fluoxetine, escitalopram, paroxetine. We're going to look at the SNRIs, duloxetine, and venlafaxine. We're going to look at the tricyclic amitriptyline, the MAO inhibitor phenelzine, and the atypical antidepressants bupropion and mirtazapine, and then the SAR1, which is trazodone. Okay, so these are antidepressants. So the SSRIs do what they sound like. They are selective serotonin reuptake inhibitors. They stop the reuptake of serotonin at the synapse, and so they're going to increase the response to serotonin. They inhibit presynaptic serotonin reuptake. So the drugs here are fluoxetine, sertraline, escitalopram, and paroxetine. Fluoxetine will be the first drug we talk about. So this is Prozac, and most of you know it. It does have probably NPLEX thing to know about this is that it has a long half-life, and longer half-life than a lot of the other ones, so it has more drug interactions than other ones. So if with Prozac or fluoxetine, you want to look at it having a longer half-life. With sertraline, this is commonly tested. This is Zoloft. It's relatively activating. It has GI side effects commonly. And actually, I didn't see this on the NPLEX review stuff, but I know that there is a class action lawsuit on sertraline for suicide, increased suicide risk when they detox off of it. Escitalopram has the higher QT prolongation at higher doses, and you do want to know with all the SSRIs that you do have some risk of QT prolongation there, non-specific to all of them. The biggest common side effects with these are sexual dysfunction, GI upset, anxiety, or insomnia can be there. Serotonin syndrome, obviously, if the serotonin gets too high. And then they may precipitate mania in some people, and they definitely have an increased suicide risk when early in the treatment process. Paroxetine also has anticholinergic effects, which its most common side effect that's complained about is weight gain. So if you see paroxetine on there, you may want to consider it in terms of weight gain, paroxetine. So the other ones that were not on this list, but you might be helpful to recognize as SSRIs are citalopram and fluvoxamine. All right, then we have the SNRIs. So these are the serotonin norepinephrine reuptake inhibitors. So these increase both serotonin and norepinephrine signaling that by inhibiting that reuptake at the nerve junction. Duloxetine and venlafaxine are the two that are tested most. They increase norepinephrine, so you're going to see an increased risk for hypertension, for insomnia and agitation, for serotonin syndrome, and major withdrawal symptoms if they stop these abruptly, generally speaking. Duloxetine is often used also for pain indication. So they use it for neuropathic pain. but it's also going to cause a risk for neuropathic pain on the detox, and it has a high hepatotoxicity risk. Venlafaxine is a dose-dependent blood pressure elevation and has severe withdrawal symptoms on it if you go off of that. Other ones here that you might want to recognize but are not necessarily tested directly for mechanism include desvenlafaxine and milnacipran, which is used more for fibromyalgia. All right, tricyclic antidepressants. So these guys are older antidepressants with a broad neurotransmitter and ion channel effects both. Often they work by inhibiting serotonin and norepinephrine reuptake, and they block cardiac sodium channels. So they are going to have different effects, including more sedation effect with it. The main one of this the main tricyclic to know is amitriptyline. Again, cardiotoxicity is the highest or key exam risk to look for. Overdose of amitriptyline can be fatal, even at relatively low doses, they said. So this one is likely on NPLEX to be, you need to look at sedation, you need to look at causing too much anticholinergic effect, and causing problems that are cardiotoxic, including cardiac arrhythmias, and then potential overdose causing death. There is an antidote for this one, is sodium bicarbonate. So if people are having this amitriptyline or TCA overdose, apparently baking soda is the sodium bicarbonate is the antidote for those. Amitriptyline is most tested for pain, migraine, and sleep, and then cardiotoxicity is the overall one that you want to probably make sure you know, other than the lethal overdose. Recognition of other tricyclics includes nortriptyline and imipramine, and desipramine and imipramine are the two there that you might want to just know if they say those are in the tricyclic categories. Both of the desipramine, they both have some. Okay, let me try again. Imipramine is historically important for enuresis in children, and then desipramine is more selective for norepinephrine, so it has fewer anticholinergic effects, but it isn't. Neither of those are necessarily on the list. So being able to just anything you might look at amines at the end or triptyline at the end, you're going to know those are tricyclic antidepressants. All right, MAO inhibitors. So the main one that these are going to inhibit MAO and MAO-A and MAO-B. So we're increasing monoamines, which include serotonin, norepinephrine, and dopamine. The main one here is phenelzine, and phenelzine has many common side effects. If you remember, this is pretty sedating and works a little bit more like at least you talked about it as working more like a hyper antihistamine type effect. But common side effects include hypertensive crisis, orthostatic hypotension, extensive drug-drug interactions with this one, and serotonin syndrome. One of the most likely questions they may ask for phenelzine is that it is tyramine-containing foods resulted in a hypertensive crisis. So I have a bunch of tyramine here, so you remember that tyramine might throw with an MOA inhibitor might cause a hypertensive crisis in this category. So other MAO inhibitors would be that are not necessarily on the list are tranylcypramine, isocarboxazid, and selegiline are the three There is a transdermal patch from the selegiline one. It wasn't on the list, so I think the only one you're going to be tested on is phenelzine, and know that it's an MAO. All right, atypical antidepressants include bupropion, mirtazapine, and trazodone. So these are antidepressants with mixed or unclear mechanisms of how they work. Mechanism varies, but they think it often is non-serotonergic dominant. Bupropion is known for having side effects, common side effects. Here, this whole list has them. So your common side effects for these guys are specifically increased norepinephrine and dopamine in the bupropion. You have a seizure risk, also minimal sexual side effects with that one. As opposed to trazodone, you're actually going to see priapism and orthostatic hypotension there. So that one actually has pretty strong sexual side effects. And then mirtazapine has sedation and weight gain. So remembering these are your atypical antidepressants. Bupropion is going to increase seizure risk. And of course, you guys would know that bupropion, I can't say that today as well, Butrin. All right, ADHD meds that are covered on the boards include dextroamphetamine, methylphenidate, atomexetine, clonidine, and modafinil. Obviously, we're trying to, with attention deficit, they're going to improve attention, impulse. They're trying to improve attention, impulse control, and executive function, but they are all stimulants. They tend to increase dopamine and norepinephrine. There is a category that are non-stimulants to modulate norepinephrine or adrenergic tone instead. So your stimulants are the dextroamphetamine, methylphenidate, atomexetine, and then your alpha-2 agonist is clonidine and modafinil. Okay, alpha-2 is clonidine, and the wakefulness agent or non-stimulant is modafinil. So let's see. Stimulants are definitely upping dopamine and norepinephrine. Amoxetine is norepinephrine only, okay, not dopamine, so it doesn't have as much abuse potential. It does, however, have the suicide warning with it, as many of them do. And then the alpha-2 agonists are sedating and lower the blood pressure. So instead of being the stimulants, the other ones are sedating and lower your blood pressure instead of putting it up. Most of the time, though, this is amphetamine, so you've got appetite suppression, weight loss, insomnia, anxiety, cardiovascular problems and effects, and obviously abuse potential because these are strong stimulants. And then you have a lot of suicidal ideation warnings happening with the non-stimulants. Anxiolytics on the test. So these are designed to reduce anxiety and autonomic arousal. They primarily are working through GABA potentiation or serotonergic potentiation. So our NPLEX pearls here. The main drugs they have on this category for anxiolytics are Alprazolam, Diazepam, and buspirone. The Benzos, the only one they put on there, is Diazepam. The other Benzos are not listed on the list as much, so I'm not sure why. But understanding that Benzos are irreversibly bind the GABA receptor, so they're going to have long-term problems. Making sure you understand the other ones that you might just want to recognize but aren't necessarily on your list are lorazepam, clonazepam, hydroxyzine, and propranolol are all ones that we use as anxiolytics. Hydroxyzine is the one that was like antihistamine effect, and propranolol, if you remember from the cardiovascular system, is used for like stage fright or social anxiety, but it's a beta blocker. So we have a lot of different categories here. Buspirone is not have a sedation effect. It also doesn't cause dependence. It does have a delayed onset. It is a serotonin 5-HT1A receptor partial agonist and a dopamine 2 receptor antagonist. So buspirone has the double whammy with adding serotonin and blocking dopamine. The brand name for buspirone is Buspar. You might have heard of it. It's an anxiolytic for general anxiety disorder most often. So unlike the benzos, it doesn't cause sedation though. So again, that's not going to knock you all the way down. Whereas lorazepam is used often in acute settings. Clonazepam is more like panic disorder, and then diazepoxide. Oh my good lord. Chlordiazepoxide is a type of benzo that's used for alcohol withdrawal. So understanding that benzos might be still in the world. Hydroxyzine, again, sedating antihistamine, and propranolol performance anxiety. There was also a listing here of pregabalin, so you might just want to remember they might throw pregabalin at, it was not on the test, pregabalin was not on the list, but understanding all these are going to have an effect on GABA. Again, your main thing that you're looking at on anxiolytics is sedation, the benzo dependence, and respiratory depression if they end up having to use the opioids. All right, and then we have a category they call mood stabilizers. So the mood stabilizers are medications that are supposed to stabilize mood and prevent manic or depressive cycling. These are often considered bipolar meds. How they work, mechanisms very often involved ion channels or neurotransmitter modulation. So we have in this category lithium, valproate and divalproex, lamotrigine, and carbamazepine. Lithium is probably the oldest school here, used as a can cause kidney issues. So looking at nephrogenic disease, hypothyroidism, and toxicity with dehydration with the lithium. Lamotrigine has a risk for Stevens-Johnson syndrome, and lithium is a mood stabilizing primarily used for bipolar to control the manic and hypomanic episodes. So you might consider that it is going to be most commonly used for stabilizing mood with bipolar. Valproate is a prescription anticonvulsant and mood stabler, so we use that for epilepsy, but they are moving it over here for bipolar disorder and migraine prevention. But it is still under the heading of mood stabilizers. Again, with anything that's an anti-seizure, you're going to see effects that can cause weight gain, sedation, liver pancreas problems, serious risk of possibly developing seizure. If it helps, valproate is absolutely not going to be used in pregnancy, or so you have to be careful with people of childbearing age. And lamotrigine is brand name Lamictal, is also an anticonvulsant, and primarily for epilepsy, but it's being used for bipolar to stabilize mood. This one comes in lots of forms, including a chewable, dissolvable form, but this one causes that really bad skin rash I think we talked about before. So it's crucial to take it as prescribed only. And then carbamazepine is Tegretol, and again, anticonvulsant. We talked about the nervous system for epilepsy, nerve pain, and trigeminal neuralgia. Then we're moving it over here to work as a bipolar disorder. And they're using it for, I thought they were using it for migraine, but I don't see it there. So again, serious risks involve skin reactions requiring monitoring. So other anticonvulsants they might throw in here, oxycarbazepine, topiramate. So topiramate is the one that causes the kidney stones and is used primarily for migraine. And then atypical antipsychotics with mood stabilizing indications would be quetiapine, olanzapine, risperidone, and aripiprazole. are all used sometimes as mood stabilizers. So again, biggest risk, acute mania versus maintenance. They're teratogenic, so don't be using the valproate in particular with pregnancy. There is organ toxicity, drug-drug interactions, Stevens-Johnson with lamotrigine, and then there's a very narrow therapeutic window with lithium where it seems to work well, but not too much. Okay, so antipsychotics, what they are, we're using them to reduce psychosis and severe mood dysregulation. They primarily work on the dopamine receptor blockade or modulate it. The biggest ones here, haloperidol, risperidone, quetiapine, aripiprazole, and clozapine. So haloperidol is Haldol. Your risks for that are epilepsy and NMS. Clozapine, it can cause a granulocytosis, and you need to be monitoring autonomic reactions. The atypicals all can have a risk of causing weight gain, dyslipidemia, and they can even cause some increased risk for diabetes. And then you want to make sure with any of the antipsychotics that you're looking for extrapyramidal symptoms, metabolic syndrome, QT prolongation, and then the neuroleptic malignant syndrome is a risk with the haloperidol as well. Whew. All right. So I'm not loving the psych meds. Glad that we're done with those. Immune pharmacology. So we've got a couple of different sections here. We're starting with the antimicrobials first. So we have under the antibacterials, we've got penicillin, let's see if I can get through and see them all. Cephalosporins, vancomycin, macrolides, tetracyclines, aminoglycosides, fluoroquinolones, sulfas, clindamycin, metronidazole, nitrofurantoin, and rifampin are going to be the primary antibacterials. Our antifungals, we're doing the azoles, the alamines, and the nystatin, basically. And then the antivirals, we have acyclovir, valacyclovir, and a couple of other antivirals up there. And then antiparasitics and antituberculars, we have 2. All right. So antimicrobials. The first thing to look at is big picture. Our antimicrobials are targeting differences between the human and microbial cells most often. So they either are going to target the cell wall synthesis, they might target protein synthesis, or they might target DNA, RNA synthesis by the bacteria, or they might target metabolic pathways. So it depends, depending on how good they are at targeting or whether they're broad spectrum, they can cause damage to our own cells. So if they're broad spectrum, they're going to have a higher risk for probiotic damage, obviously. And so you're looking at organ toxicity. You want to watch for drug-to-drug interactions. You want to watch for C. diff if it gets, especially if we have rebound, and then resistance. Okay, my antibiotics. So the main cell wall inhibitors we have on here are the penicillins. So the penicillins include pen, GMP, amoxicillin, ampicillin, and augmentin. And we have the cephalosporins here, cephaloxins, ceftriaxone, and vancomycin. And then the main NPLEX pearls to look at. Let me see if I can get through these. So we have amoxicillin, ampicillin, amoxicillin clavinulate. So that one is, that's the combo, right? That's augmentin, amoxicillin, and clavulanate. Then we have the cephalosporins that include cefazolin and ceftriaxone. And then we have the glycopeptides, vancomycin. So the main NPLEX pearl here is vancomycin is nephrotoxic. So, and can cause something called red man syndrome. So you may want to look, if you see anything that has vancomycin on it, we're looking for that red man syndrome keynote. And then penicillin allergies obviously might come up with any of the penicillins. So you might want to look for that with not using penicillin. You're going to be using cephalosporins, or they're contraindicated, or cephalosporins might be also contraindicated if there's a mild case with and a reaction to a penicillin allergy. Common side effects here are allergic reactions, GI upset, and nephrotoxicity, especially with vancomycin. Okay, antibacterials that stop protein synthesis. So that last one, those penicillins were stopping the cell wall. They were inhibiting the cell wall. And then we have these guys inhibiting protein synthesis. So this includes the macrolides, the tetracyclines, and the aminoglycosides, and then clindamycin. So the macrolides include azithromycin and clarithromycin. The tetracycline is doxycycline, and the aminoglycoside is gentamicin. And then we just have clindamycin there. Also, your big overall on your protein synthesis inhibitors, you're looking at QT prolongation. So make sure you're checking heart rate. There's hepatotoxicity, kidney toxicity, nephrotoxicity, and C. diff risk, in particular with clindamycin. So these guys are blocking ectororibosomal function, usually 30S or 50S ribosomal inhibition. Aminoglycosides are big for, so your aminoglycosides are a big deal for nephrotoxicity and ototoxicity. So that seems like a question they would be very likely to ask, I would guess, is ototoxicity with your gentamicin. And then the tetracyclines can cause photosensitivity and teeth discoloration. Clindamycin is going to increase your risk for C. diff, it says right there. And then the macrolides, those guys seem to be just in general the QT prolongation, so be careful with that. All right. Antibacterial DNA and metabolic targets. So with these guys, they're going after DNA, interfere with DNA replication, and they work with the DNA gyrase inhibitor. So this is a big deal because these are not as selective for bacteria. They tend to be more problematic. In particular, the fluoroquinolones, which is ciprofloxacin and levofloxacin, both of those fluoroquinolones are linked with tendon rupture. So, and this can be up to 10 years, she said, after the dosing of these being fluoxed, is what I've heard it said before. So fluoroquinolones cause tendon rupture. She said the research on this isn't holding because they've done the research as if one separate research for each tendon in the body. But if you put the numbers together, it does definitely increase the risk for tendon rupture. So if one of your patients comes in with a ruptured tendon, you may want to find out if they were put on a dose of these anytime in the past 2 years. Sulfas, obviously you need to check for sulfa allergies. We have metronidazole is Flagyl. I think you guys know that. That one is used for amoeba infection, anaerobic bacteria, trick, Giardia BV. That is the one that has that disulfiram-like reaction if you take alcohol with it. So if you have someone on metronidazole for BV, you need to make sure you're not giving them a tincture or any other alcohol, or they're going to get bad GI sort of symptoms. That one also depletes vitamin K, and zinc makes it more effective. So if you're looking at metronidazole or Flagyl, they need to replace their vitamin K and use zinc if you would like it to improve. It probably is going to knock the good bugs out. Rifampin is an enzyme induction. It can cause orange secretions. So remember, with rifampin, you might have some orange secretions that come out of the person. Folate pathways are inhibited, and you can have anaerobic DNA damage also. So big ones here, nitrofurantoin is kind of, she described it as the everything blocker. So the fluoroquinolones are a little bit more targeted, but they can cause that tendon rupture. Nitrofurantoin it seems to block multiple pathways, and rifampin is used. It's a little bit stronger, so I would look at those two being a lot more of a hefty hit. So with all of them, you're going to want to be sure you're checking QT prolongation, hepatotoxicity, and kidney function. All right, antifungals. So we covered this a little bit in derm, but here they are. We have the azoles, which is fluconazole and ketoconazole. We have the alamines, which is terbinafine, and we have the paulines, which are nystatin and amphotericin B. These guys treat fungal infections by targeting the ergosterol or fungal membranes. I think ergosterol, remember we said that in derm. They stop ergosterol synthesis. They disrupt the cell membranes of the fungi. So fluconazole is diflucan. It does cross the blood-brain barrier, so it can treat CSF. It is used most. The only trick with the diflucan is it does waste potassium, so that's fluconazole, waste potassium. And then if you remember, nystatin is great because it doesn't cross the gut, and so it's not well absorbed, so it's used well in GI and vaginal infections. And then terbinafine is always used for, probably the most commonly used for the toenail fungus, onychomycosis. And you definitely have to check liver enzymes because it's hepatotoxic. Again, you have another thing with QT prolongation and nephrotoxicity. So all of these have some risk with the heart and apparently, and the liver, and most of them have kidney. I think we covered the antivirals a little bit in upper respiratory, but you have acyclovir, valacyclovir, oseltamivir, and zidovudine, and hepatitis B and C antivirals. Remembering that most of the time your common side effects with your antivirals are again going to be nephrotoxicity. And then with these, you've got a possible bone marrow suppression and GI upset. So these guys inhibit viral replication, and different ones do it differently, but depends at specific life cycles. They work on the DNA polymerase inhibition, so they're neuramidase inhibition, reverse transcriptase inhibition. They could in any of those. Acyclovir has a risk of crystalluria and nephrotoxicity. Valacyclovir is a prodrug, if you're a member of acyclovir, so it absorbs better and you can dose it less frequently. Neither of those need to be taken constantly. They should only be taken during an outbreak, but a lot of times people don't know when their outbreaks are coming, so they will leave them on the valacyclovir for long periods of time. Zidovudine was used for HIV primarily, but it is not used very much anymore. She said now they're usually using a drug cocktail to treat HIV patients. So most of the time, let's see, hepatitis antivirals also, we have hepatitis B and C. Is adefovir helpful for the symptoms, but she said once it's removed, it can result in fulminant hepatitis that is deadly. So it does seem to appear to work unless you take it away, and then it can cause some mega problems in some people. It's an interferon depression, altered mental state, autoimmune, and psychotic breaks were also in there with the adefovir. Influenza A was spoken about here, but not on this slide. We talked about it before. Amantadine used to be used for it, but it's no longer recommended. And then oseltamivir is A and B. That's Tamiflu. And so off-label, it has been used for swine flu, hepatitis, but not hepatitis. Off-label, it has been also used for swine flu. It's supposed to be for influenza A and B, and that is the brand name Tamiflu. But it does cause nausea, vomiting. It can cause risk for hepatitis, and it had a huge resulting suicidal ideation, and even in children. And so that has been the biggest side effect to look for with that one. Okay, antiparasitics and antituberculars. We have albendazole, mebendazole, ivermectin, isoniazid, and rifampin here for the parasites. With all these, common side effects are too the liver and the kidney. So, the nervous system. So hepatotoxicity, neurotoxicity, and then you have to watch for drug interactions with these. They are targeting the protozoa helminths and mycobacteria. They cause microtubule disruption. So they either cause microtubule disruption, cell wall synthesis inhibition, or RNA polymerase inhibition. Isoniazid also causes neuropathy and B6 deficiency. Rifampin has an enzyme induction and causes those orange fluids. And ivermectin is tissue stage only with or basically the adult stage of the parasite it's effective with. They don't know the mechanism of action of ivermectin. They said they assumed it was the glutamate-gated chloride ion channels that were causing in the parasite that were causing the effectiveness. They also have a risk here for Mazzotti reaction response, which is like a rash, eosinophilia, lymphadenopathy, fever, and malaise, which they think may be a die-off from the parasite or possibly from the drug. So if you see Mazzotti reaction, that's like a instantaneous fever, rash, lymphadenopathy, eosinophilia. And then for the roundworms and hookworms, there's the albendazole, mebendazole, and sometimes ivermectin is in there. I think mostly it's the azoles, though, on that. Anything else there? Not on the slide. Hydroxychloroquine wasn't on the slide, but it is used for malaria. Artemisia won a Nobel Prize with that, but hydroxychloroquine is the textbook on it. And then permethrins are used for scabies, remembering permethrins are toxic to cats. All right, so those were the antimicrobials. Now we're going to go into the immune modulators and review them. Some of these were mentioned on other areas, but want to just have them in a bucket. So our immune suppression stuff, we're not recovering. That's the steroids. So if you want to go back through the steroid drugs, we had that earlier in the derm section. But there are, of course, if you're wanting to completely knock down the immune system, you would use the corticosteroids. Immune modulators are here: cytokines, monoclonal antibodies, S1P modulators, MS-associated spasticity agents, immune modulators and biologics, and then oncology drugs we're going to talk about, and vaccines. Okay, so let's talk about the immune modulators. These medications, so we don't want to completely suppress the immune with these. We're trying to alter immune system activity to reduce inflammation, usually with autoimmune disease. On these, they work by modulating cytokine signaling, so lymphocyte activity or immune cell trafficking. Obviously, if we wanted to use a full suppression, that would be the steroids or the cyclosporins, and tacrolimus are the two that we use for. I didn't talk about cyclosporins. So complete immune suppression is corticosteroids. If they have like a transplant or we need to do more direct immune suppression that way, that's the cyclosporin and tacrolimus. And these guys are used more for like MS, and JAK inhibition is their primary action. So these guys stop cytokine production, JAK inhibition, eczema, vitiligo, autoimmune disease, psoriatic arthritis, ulcerative colitis, alopecia, COVID, cytokine storms are the things they're all used for. The immune modulation from the biologic therapies is also trying to knock down cytokines, TNF inhibitors, checkpoint inhibitors, and so we have modulation of the cytokines, or we have immunosuppressants having higher risk of infection would be the main reason we're going to go for a modulator over a suppressor. Make sure if you're suppressing the immune system, obviously, or if you're modulating the immune system, that you're monitoring for infection, and pregnancy risk would be a problem here also. What do we got for drugs? We have azathioprine, so we have interferon beta, we have the glatiramer acetate again, we have fingolimod, and we have tofacitinib. We're going to talk about a couple of those on the next slide, but we're looking at nephrotoxicity. So we have increased infection risk with all these. We have injection or infusion reactions if they're on IV or injection. We have problems when you have immune suppression, and malignancy risk long term if you're on any of those. So for MS, we tend to use interferon beta, glatiramer acetate, or fingolimod. Remember, for the fingolimod, we had bradycardia, AV block, and macular edema as the main problems. With interferons, they just feel like crap, so they have flu-like symptoms and depression. And then with the glatiramer acetate, you have chest pain and injection reactions as the primaries. So remember, if you have disease-modifying therapies, you want to look at infection, neuropsychiatric effects, and then drug-induced cardiac effects. All right, then we have the monoclonal antibodies. So the monoclonals are going to have adalimumab, etanercept. Oh my Lord. All right, let me try one more time. The biologics are adalimumab, etanercept, infliximab, rituximab, and trastuzumab. So with these guys, they are targeting therapies derived from biologic systems, so they bind specific immune mediators. Some of them bind TNF-alpha, some bind cytokines, some bind receptors. They are antibodies, right? Or monoclonals. So they're monoclonal antibodies. These are going to increase risk of opportunistic infection, so be careful with them. The main overall serious infections can come from TB and fungal infections with these. Infusion reactions can have increased malignancy risk, and you can have an autoimmune phenomena from throwing in too many monoclonal antibodies. And then remember, of course, if you have if other drugs they are mentioning have umab at the end, you're looking at a monoclonal antibody. Some of the other ones they talked about were certolizumab, golimumab, ustekinumab, and omalizumab. But the main ones on the list, again, adalimumab and etanercept, infliximab, rituximab, and trastuzumab. So if you have something that's a TNF-alpha inhibitor, you have to screen for tuberculosis before starting it. So you might want to remember that for the test. If you're using monoclonal antibodies, go ahead and screen for TB first and make sure they don't have a fungal infection. Okay, then chemo and oncology. So our last little section is chemo and then vaccines. This section of this is the cytotoxic chemotherapies. So we have a few of these on the list. We have cyclophosphamide, we have methotrexate used here, we have 5-FU or 5-fluorouracil, we have cisplatin, doxorubicin, and paclitaxel. Paclitaxel are the ones that are cytotoxic. So these guys kill rapidly dividing cells. They do it in different ways, but they could be doing DNA synthesis, mitosis, or cellular replication, depending on the type. Your antimetabolites, they are alkylating agents, platinum agents, and anthracyclines. They also have microtubule stabilizers occasionally. So remember, cyclophosphamide is a bone marrow suppression, is the most universal. Methotrexate is a folate antagonist, so you need, if it's combined often with the other chemotherapies, you can give folate with it, but not anything on a higher dose. So daily doses of folate are okay. Anything over 5 milligrams may not be okay. With cisplatin, you're going to see nephrotoxicity and ototoxicity, so that is cyclophosphamide and the cisplatin are contraindicated with hearing loss because they are ototoxic, and they are contraindicated with myelosuppression. Doxorubicin is cardiotoxic, and the treatment is usually in AIDS-related Kaposi sarcoma, ovarian cancer, multiple myeloma. So be careful with cardiotoxicity with doxorubicin. 5-FU is widely cytotoxic. Anti-metabolite chemotherapy drug to inhibit DNA replication. So if you remember that it's very widely cytotoxic, it kind of kills all DNA replication and repair. Paclitaxel is also called Taxol, is widely used chemo medication. It's injected intravenously to treat various cancers like breast, ovarian, lung, and Kaposi sarcoma also. It stabilizes the microtubules, which prevents cancer deaths from dividing, leading to cell death. All right, so those are the cytotoxics. The ones that weren't on the list that might be good to recognize include vincristine, bleomycin, and etoposide. All right, and then we have targeted oncology and immunotherapies. So our main immunotherapies here. We have cancer therapies that target receptors or immune checkpoints. So they enhance immune recognition of cancers and block oncogenic signaling. So these are our targeted immunotherapies. The ones we have here are trastuzumab, which is for HER2 targeted monoclonal antibody. It's cardiotoxic, so remember it's for HER2. Trastuzumab is HER2 targeted, but it's cardiotoxic. Rituximab is anti-CD20 monoclonal for B cell depletion. It causes B cell depletion and infection risk, so you want that. Denosumab is a blocker for rankle, so remember this was used also in preventing osteoclast formation with osteoporosis. So remember this one can lead to more fragile bones, but it is sometimes used in this category as well. And thalidomide is here also. So thalidomide has a high risk for teratogenicity, so be careful not using that one in pregnancy at all. I think those are the main guys there. Recognition only. If you need to see any of the other ones for target immunotherapies would be bevacizumab, imatinib, pembrolizumab, and nivolumab also. So look for UMABs and INIBs if you're looking for target immunotherapies. And then we have the endocrine oncology. So these drugs target some tissues. Some of them are SERMs, so estrogen agonists, and some are not. They bind estrogen receptors if they're a SERM, and they have specific tissue effects in that way. So SERMs include tamoxifen and the raloxifene. I think is a SERM also. And clomiphene, if I remember right. Let's go through these one at a time. So tamoxifen it's a SERM. It has estrogen antagonist in breast tissue, agonist in bone and uterus. So that tamoxifen seems to be very specific about not damaging the ovaries and uterus, but targeting the breast tissue for keeping the estrogens down. However, it did look like it had long-term effects that were not great, with other side effects causing endometrial cancer and other things. That's tamoxifen. ER-positive breast cancer is the most common, increased risk for endometrial cancer and thromboembolism and hot flashes. So with SERMs, you're going to notice that DVT and hot flashes are common. Then raloxifene is also a SERM. And that one has bone against bone and in the breast and the uterus. Osteoporosis prevention is the plan with raloxifene. It does have increased risk of thromboembolism, no increased endometrial risk here, but it does. So tamoxifen is endometrial cancer risk. And then raloxifene is increased risk of thromboembolism. Clomiphene is a SERM also. It's an estrogen receptor antagonist at the hypothalamus, actually, blocks negative feedback and GnRH, increasing GnRH and FSH-LH ratio. So it's used in infertility, so that's clomiphene. NPLEX pearls with that are ovarian hyperstimulation. You can have, multiple eggs, multiple gestation, and visual disturbance. They are also putting anastrozole in this section, which is an aromatase inhibitor to decrease peripheral estrogen synthesis that is used for postmenopausal ER breast positive cancers. That can cause increased risk for osteoporosis, musculoskeletal pain. But it doesn't have the endometrial cancer risk as high. And then we have leuprolide sometimes added in here. Also, this is obviously not a breast cancer. Leuprolide is being used for prostate cancer. And hormone-sensitive breast cancer. That one is used across both of those. So it's a continuous GnRH agonist when used in really high doses, and it will block LHS. It will lower LHS and FSH. So it will lower luteinizing hormone and follicle-stimulating hormone, decreasing estrogen and testosterone. So basically, you're castrating someone with this, right? Lowering those. So that's used in prostate cancer and in hormone-sensitive breast cancer. With this, you'll have an initial tumor flare, hot flashes, decreased bone density. And then last, we have the megestrol acetate, which is a progestin. I think we talked about this one before. In the endocrine system, it suppresses gonadotropins and has an anti-estrogenic effect, so they do throw it in sometimes with breast and endometrial cancers. And it can cause hot flashes, vasomotor symptoms, DVT risk, and pulmonary embolism risk. And then bone density risks, endometrial effects, weight gain, all those things, ovarian stimulation. Whew. All right, so we have a whole bunch of meds that they're throwing in with the endocrine cancers. Maybe just keep in mind your tamoxifen has that endometrial cancer risk. Your bone loss is anastrozole and leuprolide, and the weight gain is megestrol acetate. All right, and then these are not on the list, but I just put a list in there if you want to look at it for the other ones that really aren't being talked about: vincristine, bleomycin, etoposide, we talked a little bit about paclitaxel, bevacizumab, those guys. So we have some monoclonal antibodies in there, and we have other ones in there that are not necessarily on the list. Okay, finally, vaccines. So last section, we are going to talk about the different vaccines. First, just the live attenuated vaccines include MMR and, am I skipping a slide here? Your live attenuated are MMR, varicella, and zoster. So you have mild infection symptoms. Their common side effects include mild infection-like symptoms, contraindicated in immunocompromised patients, and contraindicated in pregnancy. So we don't use live vaccines in pregnancy. These are weakened organisms. They do also have cholera in here that's for greater than 2 years old. Those are killed whole cells. That they're not. Those are not attenuated. They're killed. Another thing here to look at is what do we got? Let's go through. Yeah, cholera's on the next slide. So with your attenuated, I don't want to talk about MMR. We know MMR and varicella. Varicella is recommended at like age 2 and age 12, I believe. And then let me make sure I get it right. Age is 2 doses, age 1 and age 4 to 6. And then zoster is recommended at age 50 plus. So we have those for varicella. MMR has got 2 doses recommended, childhood and then teen. And remembering, at least in my practice, I've seen MMR have the highest risk for retrovirus reaction. Don't see that on the NPLEX, however. And then the inactivated or recombinants are influenza A. Influenza is recommended at 6 months to age 49 every year. HIB is 2, 4, and 6 months. HIB has no clinical trials showing its effectiveness in anyone, including children, is what was said there. The DPT or DipTet, remembering DTaP is for kids. So DTaP means, diphtheria, pertussis, and diphtheria and pertussis. And Tdap is the booster. So if you remember, if the first dose is called DTaP and the Tdap is the booster for adults. And then we have the cholera is given twice, ages 2 and, let me look. Where's my cholera? Yes, so cholera has 2 doses. It's fully killed. It has 2 doses at age 2 years old, and then another dose some other time. Hep A and Hep B. So let's see, where's mine? Pneumococcus is 4 doses, often given with DTaP. MMR is 12 to 15 months, and then 4 to 6 years. Meningococcal polysaccharide is at age 1, and then a booster at age 16. Polio gets 4 doses, 2, 4, 6, and 12 on polio. Hep B is recommended at birth, despite the fact that we can't possibly get it at birth, since they wouldn't be having sex or sharing fluids. But it has a series. Hep B has recommended at birth, 1 to 3 months, and 6 months. Hep A has a recommendation of 2 doses, 12 to 23 months, and second dose or 2 doses between 12 to 23 months. And it looks like a second dose at 16 years, something like that. She did say Hep A is self-limiting and doesn't necessarily need to have that as an immunization. HPV is suggested as a 3-dose series in girls 11 to 12 and boys 11 to 12 now too. That is not used in any other countries now due to female death. We have RGE, which is the rotavirus, now is being given at 2, 4, and 6 months. And our big thing is none of these are safe with immunocompromised patients. Multiple doses are required for effectiveness. Adjuvants enhance immune response, supposedly there. So making sure that you understand the idea of boosters, etc. It didn't go off about all the horribleness. All right, we made it. So next week we're going to review hopefully kind of the keynotes of everything, and we will then be ready for the exam. Thanks for playing.